Uh, Dr. Botha, I think we can start your session so that we can end on time.
Thank you very much. Thank you very
So,
much.
before you start, let me welcome all the participants, and I'm really grateful to you for joining us today as a speaker. And thank you, and also thanks to Dr. Madhya, who has recommended your name for the critical care. And we already knew because you were here in the PSA conference. So let me give a brief introduction of yours. Dr. Botha has done his undergraduate and postgraduate training in South Africa. He did his nephrology training at the Hammersmith Hospital in London and a critical care fellowship in Vancouver, Canada. Dr. Botha has been working as a senior intensivist in Australia since 1996. He was an examiner for the Australian College of Intensive Care for 12 years and director of intensive care at Peninsula Health, Melbourne from 2000 till 2022. He is on the board of Australia New Zealand Intensive Care Society and has an adjunct professional appointment in Monash University, Australia. He has published extensively and is actively involved in global health. So I welcome Dr. Botha. Thank you so very much for joining us today, and I'm looking forward to your excellent speech today.
Thank you very much, Asma. Thank you very much. And good evening to all my colleagues in Pakistan. It's a real pleasure to have the opportunity to share my insights with you this evening. And as you probably heard, I've had two trips to Pakistan before. The first trip to Rawalpindi, year before last, and earlier this year to Karachi, which I thoroughly enjoyed. So this evening, I'm going to talk on acute kidney injury and really highlight, in the next 45 minutes, a few aspects of the problems we may face with acute kidney injury. So let me just see what problems I'm having here at the moment in advancing my slide. My apologies for this, but I've just got, for the moment, a frozen screen, which is most embarrassing. Absolutely embarrassing that my computer screen has frozen. And so we now sit with a situation that's going to delay you all for a short while, and I do apologize for that. So let's just go again and see whether we have success with that. Yes, better. Thank you. So we'll firstly talk about the pathophysiology of acute kidney injury, and I'd like to outline some of the difficulties in fully understanding the pathophysiology of acute kidney injury. I'll then move on to the epidemiology and talk briefly about which patients get acute kidney injury and what the associated comorbidities with this condition may well be. I'm going to talk about the definition because, of course, the definitions can vary from doctor to doctor, and the standardized definition is clearly important if we all wish to be talking the same language. I'm going to move on and talk about the diagnostic approach to acute kidney injury and how we as clinicians can make a clinical diagnosis that can hopefully affect our management. I'm then going to talk about the medical management of acute kidney injury, moving on to the different modes of renal replacement therapy, and then finally talk about the long-term outcomes of patients who end up with acute kidney injury. Now, importantly, the pathophysiology of acute kidney injury is complex, and this is particularly the case in patients who have septic acute kidney injury. And of course, for many of you working in the acute care environment, much of your renal failure is going to be septic acute kidney injury. And it's important to understand that the kidney, like many other organs such as the lung, is at risk of hyperoxia, and at the same time, also at risk of hypoxia. And in the forthcoming few slides, I'll share with you some of the animal data we have on septic acute kidney injuries and some of the human data. Now, importantly, despite the dangers of hyperoxia that the mammalian kidney may be subject to, what is good news is that we have inherent structural antioxidant defenses to deal with O2 excess. And this is primarily because arteries and veins are very closely associated. And this close association between arteries and veins facilitates countercurrent diffusion and enables a high degree of AB shunting of oxygen from arteries to veins in the kidney. And it's this AB shunting in the kidney that removes a significant amount of oxygen even before it gets to the kidney. So let me expand this concept. This diagram shows very carefully what close coupling occurs in the kidney and how this facilitates countercurrent O2 diffusion. And looking carefully at the difference of the structure between the association between the artery and vein on the left-hand side of the kidney, as opposed to that in skeletal muscle, we can see that on the left-hand side of your screen, the association between the vein and the artery is quite unique in the kidney, and we have this unique periarterial structure whereby the vein and artery are in close proximity, thereby facilitating O2 shunting from artery to vein. And importantly, this system is servo-controlled to maintain homeostasis. So on the left-hand side, when the blood flow is relatively slow, the amount of AV shunting is relatively small, as opposed to a scenario where there is a high renal blood flow and a far greater amount of AV shunting occurring from the artery to vein. So this is the latent inherent protective mechanism, how the kidney protects itself because of the anatomy and because of this servo-controlled homeostasis that occurs. Professor Beloma's group at the Austin Hospital in Melbourne have done some unique work looking at the septic model of acute kidney injury. And this is data looking at renal blood flow in the septic sheep kidney model. So sheep was anesthetized, sepsis was induced, and renal blood flow was monitored. And contrary to what some of the early teaching may well have been, that renal blood flow decreases during sepsis, these data to show that from the onset of the septic insult, with the passage of time on the x-axis, the renal blood flow in fact increases. And importantly, this increase in renal blood flow is noted not only in the cortex, where you initially have a small fall and then a subsequent increase in renal blood flow with time, but the same occurs when we review the association between blood flow in the medulla over the passage of time. So both cortical blood flow increases with time and medullary blood flow increase with time in the septic acute kidney injury model. But what is confusing is that there is a cortico-medullary dissociation, in that the cortical PO2 goes up, but in contrast to that, the medullary PO2 falls. So we have the so-called cortico-medullary dissociation. And if we review the PO2 in the human kidney, it's been well studied and shown that the medulla has a very, very low PO2 when compared to the PO2, which is more proximal, or rather more cortical. And it's a significant medullary PO2, which really does place the tubules at great risk of tubular necrosis. Now, what's even more confusing for us to better understand how we can manage our patients is, once again, some work from Beloma's group, where they were able to measure renal blood flow using a very sophisticated technique called phase contrast magnetic resonance imaging in the septic acute kidney injury model. And what they found was that there was no clear association between renal blood flow and creatinine clearance in patients with septic acute kidney injury. So we would assume that as blood flow increases, there would be an increase in creatinine clearance, but this is not the case. And this bottom slide here, slide number C, shows that there's really no clear linear association between creatinine clearance and renal blood flow. So what does this mean for the practicing clinician? It leaves us with a true clinical dilemma, because we know from these data that global renal blood flow can be dissociated from GFR, medullary flow, and medullary O2. At the bedside, we can't reliably and consistently measure global renal blood flow. And if we increase renal blood flow, which we really don't know how to do reliably, we may increase GFR, but an increase in GFR may cause medullary ischemia. And of course, if we increase renal blood flow, this may increase superoxide generation, which may kill tubular cells. So this is not particularly helpful, but I think it explains some of the dilemmas we as clinicians face at the bedside when we try and improve renal blood flow, hoping this is going to, in fact, improve the outcome of our patients and consistently lead to changes in GFR, etc. I'd now like to move on to the epidemiology of acute renal failure and share with you some data published in JAMA almost 20 years ago, a large epidemiological study, which really gives us quite a bit of insight into what happens to patients with acute kidney injury. And this study was conducted at 44 centers in 23 countries, as I mentioned, almost 20 years ago. Patients were included in the study if they had either renal replacement therapy during their stay in ICU or fulfilled one criteria for acute renal failure, be that oliguria of less than 200 mils in 12 hours or azotemia with the blood urea nitrogen greater than 30. Patients with dialysis or end-stage renal failure prior to admission were excluded from the study. Almost 30,000 patients were admitted to ICU at the 4 study centers during this period, and the period prevalence of acute renal failure ranged from 1.4% to 25.9% across all the centers. And the median SAP score, the simplified acute physiological scoring system, was 48, so the patients were quite sick. Let us now look at the contributing factors as to why these patients were thought to develop acute renal kidney, or rather acute kidney injury. Well, almost half the patients had a diagnosis of septic shock. Just over a third had had major surgery at the time of the ICU admission. Just over a quarter were diagnosed with cardiogenic shock. Hypovolemia occurred in a large proportion of patients, and about 1/5 of patients were thought to have a drug-induced acute kidney injury. A smaller number had the rare condition called hepatorenal syndrome, and about 2.6% of patients had an obstetric cause for their acute kidney injury. If you look at the characteristics of these patients in the intensive care unit, they were sick. Over 60% were males, about 75% were ventilated, and the vast majority, almost 70%, were in some form of vasoactive agent. If we look at the mode of renal replacement therapy, almost 80% had some form of continuous renal replacement therapy, about 15% intermittent dialysis, and an even smaller percentage had either peritoneal dialysis or slow continuous ultrafiltration. What was the conclusion of this large study? Well, renal failure was quite common. Acute kidney injury was found in about 5.7% of patients. What was noted was that the observed mortality was significantly higher than the SAPS-2 predicted mortality, 60.3 versus 45.6%. So these data imply that if you've got an acute kidney injury, your mortality is high and higher than what the scoring systems at the time predicted. So it's likely, therefore, that the SAPS-2 score underestimates mortality in acute renal failure. And importantly, most survivors of acute renal failure, about 80%, were dialysis-free at the time of hospital discharge. I found this information useful to share with my patients and their families, because if they say, "Doctor, I've got kidney failure in the ICU, am I likely to need dialysis when you leave?" I can say to them with a certain degree of confidence that if they are to survive the ICU stay, where we know the mortality with acute kidney injury is about 50%, the vast majority of the patients will leave the survivors rather, will leave intensive care off renal replacement therapy. We'll now talk about definitions. Many of you would have heard of the Rifle criteria, which is a validated criteria, a scoring criteria to really look at the severity of acute renal injury. And the Rifle criteria are important because we know that as you move down the cascade from risk on the top left-hand corner to end-stage renal failure, your hospital length of stay increases, your ICU length of stay increases, and your mortality increases. Now, patients can be classified into these 5 stages based on whether they are at risk, injury, failure, loss, or end-stage renal failure, hence the acronym RIFLE, and they meet criteria based on either a change in creatinine on the left of your screen or a change in urine output. So they're at risk if the creatinine rises by 1.5 times of normal or more than 25 to 50% of baseline. And so you move down, injury is twice normal, failure is 3 times normal, and the degree and duration of oliguria changes. And finally, loss implies that you've had acute kidney injury with loss of renal function for more than 4 weeks, and end-stage renal failure implies that you've had no kidney function for 3 months. And these scoring systems are important because they are associated with patient outcomes, ICU length of stay, hospital length of stay, and mortality. I'm now going to move on to the differential diagnosis of acute renal failure. And importantly, as most of you would be well familiar with, renal failure, or rather acute kidney injury, can be classified as pre-renal, intrinsic, or post-renal. And the diagnosis is usually made on the history, the physical examination, hematological or serological investigations, urine microscopy, and of course, don't forget the important role of radiology. I'm now going to draw your attention to the anatomy of the renal corpuscle because intrinsic renal injury affects various parts of the renal corpuscle. I'm once again going to highlight to you the importance of the afferent arteriole and the efferent arteriole and how the inflow of blood into the corpuscle and the leaving of blood from the corpuscle regulates the glomerular perfusion pressure. And this is important, particularly if you review the nephrotoxicity of ACE inhibitors. Angiotensin II primarily affects the efferent arteriole. So if the effects of angiotensin II are lost by administering an ACE inhibitor, and you in fact decrease the constriction of the efferent arteriole, the glomerular perfusion pressure falls, and you develop a renal injury. I also want to highlight the importance of the renal mesangium, which of course is at great risk of some drug-induced renal insults, particularly interstitial nephritis. And then, of course, the tubules, the distal and proximal convoluted tubules where ATN occurs. Let's now briefly talk about pre-renal causes. Some are self-evident, but sometimes one needs to think about what may in fact not be that evident. So the pre-renal causes, which are usually self-evident, are situations such as dehydration from diarrhea or diuretics or illness, but don't underestimate the importance of congestive cardiac failure in decreasing the renal blood flow, the importance of undiagnosed renal artery stenosis as a pre-renal cause, and be particularly mindful of that condition in patients who are known to have vascular disease, be that coronary artery disease, cerebrovascular disease, or peripheral vascular disease. And I, of course, already alluded to drugs that can either affect the vasomotion of the afferent and efferent arterioles, and then, of course, antihypertensive agents that drop the renal perfusion pressure. If we look particularly at renal intrinsic causes, acute tubular necrosis is probably the most common cause of renal failure you will see in your ICU or your theatres. Do not forget the importance of pre-existent diabetes and hypertension, and remember the association between GFR and how the GFR is something which falls off very, very precipitously once you reach that inflection point. There are so many, many nephrotoxins, non-steroidal drugs, ACE inhibitors, contrast agents. Be mindful of those. And then remember that not all your patients are going to have something such as acute tubular necrosis. They may sometimes, in fact, present into your intensive care unit with nephritic cause for the acute renal failure. So any patients with the rash or arthralgia or Raynaud's, think about something more exotic, such as a vasculitis. Important to exclude a post-renal cause, prostatitism in men, bladder neck obstruction, renal calculi, particularly bilateral, pelvic malignancies in females, and then the importance, of course, of retroperitoneal fibrosis, which can be very difficult to diagnose. So to once again highlight the importance of the physical examination and that not all patients have got acute tubular necrosis, here's an example of somebody with Wegener's granulomatosis who's lost the vomer bone of the nose, so they've got the saddle nose deformity with a CT scan, very abnormal with these large parenchymal granulomas, a leukocytic vasculitis over the lower limbs, and urine microscopy, which reveals classic red cell casts, dysmorphic red cells on urine microscopy. And of course, here we have the various stages of a patient who has got a mild hydronephrosis on the left, a moderate hydronephrosis in the middle, and severe hydronephrosis on the right-hand side. So importantly, always catheterize your patient and be very mindful of the patient who have an atypical presentation of an obstructive uropathy. I'm going to spend a little bit of time on this slide because I think it's important. Oliguria is in reality all we can truly measure with any consistency at the bedside. Yes, you could argue that there are some novel markers of acute kidney injury, such as NGAL and cystatin C, but they are not widely available, certainly not widely available in Australia, and I would imagine not widely available in Pakistan. So the early sign of a potential acute kidney injury is oliguria, and I can't stress how important it is to recognize oliguria in the early stage, because if it's not recognized, there is then worsening ischemia and ultimately acute tubular necrosis. And this area here is very, very difficult to unravel at the bedside. If the patient's undervolumed and dehydrated, we can restore volume and we can do some simple tests to establish that the problem is largely pre-renal. Classically, a high urine osmolality in the early stage of the undervolumed patient and a concentrated urinary sodium. Once the patient has progressed to acute tubular necrosis, we have tubules which are now clogged with granular casts. The kidneys can now no longer concentrate urine, so the urine becomes dilute of a low osmolality, and of course the kidneys can now no longer retain sodium, so there's lots of sodium lost in the urine. To prevent this worsening ischemia, what we at the bedside can do is resuscitate the patient, i.e. restore the mean arterial pressure, deliver intravascular volume, and treat correctable factors, remove nephrotoxic drugs, and exclude obstruction. Those are the important things we can do. Renal biopsy is seldom done in the acute setting because the vast majority of our patients we know will have probable acute tubular necrosis. But there is sometimes an indication for a renal biopsy in acute kidney injury, particularly in patients who have a rapid deterioration of renal function with an abnormal urinary sediment, red cell casts. One would consider a renal biopsy in patients who've got significant proteinuria and hematuria particularly more than a gram of protein a day. And there's a relative indication for biopsy with isolated proteinuria. I'm now going to talk further about how we can optimize a patient's hemodynamics, and importantly, whether there's any role of optimizing blood pressure in patients with septic shock. So I'm now going to draw your attention to this publication, the sepsis spam publication, almost a decade ago in the New England Journal, in which patients in a multi-label, open-label trial, multi-center trial, I apologize, were randomly assigned to undergo resuscitation with either a mean arterial pressure target of 80 or a lower pressure of 65 to 70. Maybe we could just get on mute there. I'm hearing a little bit of noise, which I think can be difficult with the other members. If you could just put yourselves on mute, thank you so much. Could we ask the listeners just to go on mute if they're not currently asking a question? Thank you. So importantly, these patients were randomized with septic shock to either a higher mean arterial pressure of 80 to 85 as opposed to a lower pressure of 65 to 70. The assumption being that a higher mean arterial pressure is beneficial to the kidney, the primary endpoint being mortality at day 28. Well, disappointingly, if we look at the primary endpoint of mortality, there was absolutely no difference in these two groups of patients at their 28 and 60-day mortality, be they in the high target group with a higher targeted mean arterial pressure or the low target group. But there was some interesting data from the secondary endpoints. And as anticipated, in those patients who were targeted to have a higher mean arterial pressure, on days 1 to 5, those patients who were targeted for a higher pressure had a statistically significantly increased dosage of noradrenaline administered. And moving down, not unexpectedly, those patients also had more atrial fibrillation, considering they were given more noradrenaline. But I think what is something you do need to consider from these data is that in those patients who had chronic hypertension, there seemed to be an advantage in targeting a higher mean arterial pressure, because these data showed that as a secondary outcome, the need for renal replacement therapy was lower in chronic hypertensive patients who had a higher targeted blood pressure. So I often say to my registrars, in young patients with normal endothelium with no underlying vascular disease, a mean arterial pressure of 65 to 70 would be reasonable. In the elderly patient, particularly the elderly patient with atherosclerotic disease, be that coronary artery disease or peripheral vascular disease, there probably is an advantage in targeting a higher mean arterial pressure. I understand you've had lectures on fluid therapy. I do, however, once again want to highlight the dangers of giving synthetic starches to the septic patient. And some of you will be familiar with the Anders Pernes data, which was the comparison of hydroxyethyl starch with Ringer's acetate and severe sepsis, and of course, the Australasian chest study, which was John Meyerbeck's group, also published in the New England Journal. And I'm going to focus more on the chest study. So this was a study comparing hydroxyethyl starch or saline for fluid resuscitation in the intensive care unit. And of course, hydroxyethyl starch, marketed as Voluben, is a maize-based starch. So this was a total of a large number of patients who were randomized to either hydroxyethyl starch or to saline and sepsis. There was no difference in mortality in the 6 predefined groups, but what was important was that there was a greater use of renal replacement therapy in the group of patients who had hydroxyethyl starch. So these data do show that this starch causes kidney injury. So the mortality data, no different, but as I've mentioned, a greater need for renal replacement therapy. And if we look at these graphs here, it shows to us quite clearly that if we look at serum creatinine on the y-axis and we compare saline versus hydroxyethyl starch, those on the starch had a higher serum creatinine, and the urine output was also greater in patients who had saline. And for those patients who did have a renal biopsy, they found this unique osmotic nephrosis lesion in patients who were exposed to starch, as opposed to the normal tubular section as depicted by this triangle there. We know that there are potentially some dangers of delivering chloride to the kidney. And this was also a study which was interesting, a before and after study comparing a chloride liberal with a chloride restrictive fluid in patients who were critically ill in an intensive care unit in Melbourne. So this was a prospective open label sequential period pilot study of 760 patients admitted consecutively to the intensive care unit during the control period, compared with a similar number of patients admitted consecutively during the intervention period when patients were given a chloride restrictive fluid with the belief that chloride was potentially bad for the kidney. So during the control period, patients received standard intravenous fluid. After a 6-month phase-out period, any use of chloride-rich fluids was restricted. And what did that show? That showed that patients in the intervention period had a lower risk of both injury and failure, 8.4% as opposed to 14%. But this was an interesting study, an old study, which really showed in this fairly simple before and after design that chloride was potentially bad for the kidney. So in terms of correctable factors, restore the intravascular volume, and particularly in the septic patient, avoid synthetic starches. Probably also wise to avoid fluid-rich in chloride. Restore the blood pressure, and if you're going to restore the blood pressure, it's more important to do so in the elderly, atherosclerotic, hypertensive patient. Treat infection early, as would be required in all cases of sepsis, but particularly abdominal infection. Avoid nephrotoxins, and what I usually tend to do is stop all drugs that are not essential for the treatment at that particular point in time. Be mindful of the undiagnosed, unrecognized intra-abdominal compartment syndrome in patients who had multiple laparotomies, because we know that the clinical assessment of the intra-abdominal pressure is notoriously unreliable. Consider rhabdomyolysis, because unless you test the CK or look for myoglobin in the urine, you're not going to make the diagnosis. Don't miss the unrecognized disseminated carcinoma with hypercalcemia. So check the CK and check the calcium, and of course obstruction. If it's outflow obstruction at the prostate or the cervix, that's sometimes not that difficult to diagnose, but you can sometimes be caught out with unrecognized retroperitoneal fibrosis. Now, when to start renal replacement therapy is another topic I'm going to talk on. What kind of renal replacement therapy to deliver? How intense should the renal replacement therapy be? What anticoagulation to use? And finally, what do we tell our families with loved ones in the intensive care unit who've developed acute kidney injury? So when to start renal replacement therapy? Well, all of us know that if the patient's acidotic with a pH less than 7.2, we would recommend starting renal replacement therapy, because in the critically ill, inotropes don't work well with a pH less than 7.2. If they've got hyperkalemia that doesn't respond to medical management, we would need to initiate renal replacement therapy. And of course, fluid overload in the patient who is not diuresing would need to be strongly considered for renal replacement therapy and fluid removal. But of course, is there an arbitrary creatinine whereby we should start renal replacement therapy, assuming those life-saving renal replacement therapies are not indicated for hyperkalemia, acidemia, or fluid overload? So I'll draw your attention to the Acute study published about 7 years ago. And this was a study in 31 ICUs in France, performed between 2013 and 2016, in 620 critically ill patients with severe AKI. And they were randomized to either early renal replacement therapy within 6 hours of randomization if they met the criteria for acute kidney injury. And I won't go into those, but there was certainly a degree of azotemia and oliguria. Or delayed renal replacement therapy, whereby renal replacement therapy was only initiated for significant hyperkalemia, acidosis, or fluid overload. And what they found was no statistical difference in mortality at 60 days. But they did find that in patients who were randomized to early renal replacement therapy, as anticipated, the vast majority, almost all these patients, ended up on renal replacement therapy, whereby those who had the delayed strategy, only about 50%, ultimately ended up requiring renal replacement therapy. So this study certainly has informed many of us to hold off on some form of dialysis unless they have those absolute criteria. And the conclusion from the study was that a delayed strategy reduced the number of patients who needed renal replacement therapy, and there was no difference in vasopressor-free days, ventilator-free days, ICU stay, hospital stay between the two observed patients. Now, what about the timing of renal replacement therapy? In patients with acute kidney injury and sepsis, another study showed very, very similar data. No difference at all between early and delayed strategy. And this was also shown by the START AKI investigators, the Australasian Canadian group. Once again, if we look at the patients who had standard as opposed to accelerate, and we look at the survival curves 28 days and even 68 days after randomization, no difference. So I think there's enough good data to show that early renal replacement therapy is probably not indicated and is not going to save lives, and that by delaying it, you can probably save a number of patients the necessity for starting renal replacement therapy. Now, what about the type of renal replacement therapy? Should you deliver intermittent or continuous? Now, I do appreciate that this will often be determined by the circumstances in your own unit, but let's talk a little bit about the theory and compare the two types. Well, many of you will be familiar with intermittent dialysis. It's been around for a long time. And when I was a medical and ICU registrar decades ago, that's all we had. But of course, with intermittent dialysis, you need to have dialysis available. You need some sort of reverse osmosis machine. So it's quite difficult to set up in your unit. The unit has to be plumbed for that. There are certain advantages of this mode. Patients can be liberated from the machine if they don't require dialysis all the time. It lowers potassium more quickly. It can be useful for eliminating drugs more quickly. But of course, the danger is higher blood flow rates. So theoretically, there were concerns that these higher blood flow rates would compromise the circulation in critically ill patients and not be advantageous, as opposed to some form of continuous renal replacement therapy, CVHDF, etc. And this is the typical Prism Flex machine. And of course, it was hoped that when these machines were widely deployed, because they were considered more gentle and more gentle in the circulation, that outcomes may be better. In many of our intensive care units, we only have this available because our nurses can deliver the therapy. You don't need to have your unit particularly plumbed. So is there any difference between the two? Well, the first real study that looked at this was Ravindra Mehta's group from the western coast of America, They did a multi-center randomized trial comparing intermittent and continuous. 166 patients were randomized, and they found there was absolutely no evidence of survival benefit for continuous dialysis as opposed to intermittent. And then there have been a number of post hoc analyses looking at renal outcomes according to renal replacement therapy and modality in the ATN and renal trials done by Gallagher and Belomo. No difference at all if you looked at this cumulative data and survival, whether you use intermittent or continuous renal replacement therapy. The p-value certainly not statistically significant. What about the type of anticoagulation? If you are going to put a patient on a filter, does it matter whether you use heparin or whether you use something more novel, such as citrate? This was a small study done in about 8 units by David Gattis's group, comparing regional citrate anticoagulation with regional heparin protamine. And the primary outcome was filter survival. And what they found was that in patients who were placed on citrate, the median survival was 39 hours, as opposed to the median filter survival being 22.8 hours in patients who were on heparin. So we tend to routinely use citrate now, bearing in mind that citrate has to be used with extreme caution in patients who have hepatic injury, and you need to constantly watch the acid-base status and replenish the citrate, because the calcium, because of course this gets chelated by the citrate. What about the dose of renal replacement therapy? Is more dialysis better? And does increased dialysis improve patient outcomes? So if we review the intensity of renal support in patients receiving intermittent dialysis, the Veteran Affairs NIH study looked at this very carefully. These were patients who were being treated with intermittent dialysis. For those in the intensive management arm, they were dialyzed with intermittent dialysis 6 times a week, as opposed to those in the conventional arm who were only dialyzed 3 times a week. If the patients were hemodynamically unstable, they reverted to a form of continuous renal replacement therapy with a higher volume of effluent in the intensive arm, as opposed to only 20 milliliters per kilogram in the conventional arm. The primary endpoint, 60-day all-cause mortality. Absolutely no difference in outcomes between those patients who were given dialysis 6 times a week as opposed to those with less intensive therapy. And of course, a study was then done comparing 2 modes of continuous renal replacement therapy. This, of course, is the renal trial, which was a large trial conducted by the ANZEX Group's Clinical Trials Group, published in the New England Journal of Medicine in 2009. And in this study, patients who were receiving standard renal replacement therapy were assigned to an effluent of 25 milliliters per kilogram per hour, which really determined the amount of clearance we were going to get, as opposed to the augmented group, who were given an effluent of 40 milliliters per kilogram per hour. And the study design was designed in such a way based on some data from Claudio Ronca's group, which showed a smaller study benefit of an augmented continuous renal replacement effluent. And the bottom line was that there was absolutely no difference at all, once again, in those patients randomized to a higher versus lower dose of continuous renal replacement therapy. So 2 studies, both in the intermittent and continuous group, no advantage of more aggressive renal replacement therapy. Now, of course, many of us are aware that if our patients remain in the intensive care unit for a long time, they may start off looking nice and thin. And if we don't pay careful attention to their fluid status, they end up looking like the Michelin man, very positive in fluid balance and difficult to manage. And there was an observational study looking at the fluid balance and patient outcomes in the renal trial and looking at the cumulative fluid balance in these particular 2 groups. And what they found was that a negative mean daily fluid balance was independently associated with a decreased risk of death at 90 days in those patients who were enrolled in the trial. So the take-home message here is too much fluid is not just bad for the lungs and bad for ulcers and bad for absorption of nutrients and causing pulmonary edema. It's also potentially bad for the kidney, and in the renal study analysis was shown to be associated with death if you were positive. And what about long-term survival? The post-renal study followed up patients who were enrolled in the renal study after ICU discharge. And even though I said earlier that if patients survive the ICU, having had renal replacement therapy, the vast majority will leave dialysis-free. The post-renal study, where they looked at tertiary outcomes at 162 patients in the one group and 188 in the other group who were assigned to lower intensity, they found that with the passage of time, there was a definite fall off in survival. And they found that, in fact, BU in the higher intensity group or the lower intensity group, your median survival after leaving ICU was only about 8 months. And as you extend the time interval out, the vast majority of these patients were no longer alive, which of course is disappointing considering how hard we've all worked to deliver renal replacement therapy and hope for a better outcome. So the final slide I want to share with you is the following: recognize acute kidney injury and try to prevent progression, even though that's difficult. Maintain that intravascular volume and don't use synthetic starches, and keep the blood pressure up early on, particularly in the hypertensive elderly. Stop all nephrotoxic agents and be mindful of those where you least likely suspect them to be nephrotoxic, such as proton pump inhibitors, various antibiotics. Exclude obstruction. Early renal replacement therapy is unlikely to change outcome in terms of mortality. The mode of renal replacement therapy does not affect mortality. The intensity of renal replacement therapy does not affect mortality. Avoid a positive fluid balance, because there are a number of studies to show in patients who have been dialyzed or those who did not require dialysis with acute kidney injury that a positive fluid balance is bad for you. And that in patients who leave ICU after renal replacement therapy, even though initially they may do well, with the passage of time, the post-renal study does show that these patients persist with the high mortality. So I've tried to keep to time, and we've got about 10 minutes left, and I'm really happy to answer any questions on a topic which remains fascinating, remains difficult, and remains challenging. So welcome to questions. Thank you for your time.
Thank you so much, Dr. Botha, for your talk. It definitely was quite an extensive topic, and you have covered all the important points here. So I would request everyone, especially my participants, to please write their questions in the chat box or either unmute their mic so that they can ask the questions. We would like to have many questions on acute renal injury. So yes,
Good
Dr.
morning.
Saad Salman, can you please unmute yourself?
Sure. Good morning. I'm Dr. Saad Salman from Peshawar. I'm currently a resident anesthesiologist. So my question is, am I right to understand that so far there has been any intervention which can actually prevent this AKI or enhance the recovery if AKI develops, or prevent AKI apart from stopping nephrotoxic agents and keeping the intravascular volume and blood pressure? Am I right to?
Yeah. Dr. Saad, unfortunately, your conclusion is correct. There have been so many different agents that have been looked at over time to try and prevent the development of acute kidney injury. We know, for example, that when dopamine was first advertised by Eli Lilly almost 30 years ago, with the theory that improved splanchnic blood flow, there was hope that this drug was going to, in fact, avert acute kidney injury in septic patients and other patients with abnormal perfusion. But one of the early trials done by the Australasian Clinical Trials Group was the dopamine study, which really randomized patients to control in dopamine. And it really did show that dopamine, which was the great hope, did not alter outcome in patients with acute kidney injury. So you are right. At the moment, we do not have a drug which can switch off acute kidney injury developing to acute tubular necrosis. I'm talking specifically about acute tubular necrosis, not the vasculitides, not the intrinsic problems where you've got specific therapies, but acute tubular necrosis. Your assumption is quite correct, Dr. Saad.
Another participant, Dr. Shahryar Beg, has asked about the most sensitive indicator of acute kidney injury.
Okay, so as mentioned, there have been many substances looked at to try and predict which patients are going to develop acute kidney injury. And the problem really is that the ones that are available and that are more sensitive, and I think the ones that have probably been looked at most extensively are, as I mentioned earlier, both Angel and cystatin C. The problem really with those is that even though they may have a greater sensitivity in monitoring the urine output, the problem there is that by the time you get those results back, should you have them available in your lab, the patient has already probably picked up their kidney injury. So even though they are tools, which certainly have been used experimentally and have been studied, they have not really found widespread practical use in the intensive care unit or the operating theatre for that matter. But if you had to, I think if you had to try and establish in the early stages whether you're dealing with a pre-renal problem or a post-renal problem, probably what would be useful would be the osmolality of the urine being concentrated in the pre-renal stage and dilute in the post-renal stage, and the urinary sodium concentration low in the pre-renal stage in the urine and high once you've got established tubular necrosis.
Thank you, Dr. Botha. So we have more questions. You are all free to ask questions. In the meanwhile, Dr. Botha, what is in your experience in the critical care? Have you seen patients what is the percentage in your hospitals actually in the developed world of the patients having acute kidney injury, as well as those patients who are on CRRT versus on intermittent coming out of kidney injury?
Okay, right. So thank you for that question. So as you may recall, from that very early slide I showed, which was the best study, one of the very early slides to look at epidemiology, the data from that study, which was done in a whole lot of intensive care units around the world, we have it there. This was a multinational study, and of course Australasia was included in that study, and we can see that the point prevalence of acute kidney injury vary between 1.4 and 25.9% across all centers. In Australasian intensive care units, as I recall the data, it's rather 10 to 15% mark. The mortality of acute kidney injury in Australasia is around about 47, 48%, marginally better than the data for all units around the world. And that may well be because we're very well resourced with a very high nurse to patient ratio. But I think the take-home message there is that data from the epidemiological study, which I showed you, it's about 1.4 to 25.9% in our own ICU. It's slightly lower than 25.9%, and the mortality about 47%. And once again, in patients who survive the ICU, almost 90% leave the ICU not requiring renal replacement therapy. In terms of the mode of renal replacement therapy that we use, it would be most uncommon to use intermittent hemodialysis in the Australasian intensive care units. We tend to routinely use continuous renal replacement therapy with the Prisma Flex machine because our nurses can initiate it, so we're not dependent on our nephrologists for arriving and bringing out the kidney machine.
That's so nice to know. So do we have any more questions for Dr. Botha, or shall we be closing our session for today? Okay, so now we have got a question from Dr. Danish Shams, and he's asking about the role of acetylcysteine used in acute kidney injury study-based.
Okay, so acetylcysteine really first received quite significant attention from a study by Teppel's group, which was published, or that would have been, I would say, about 15, 18 years ago, in which they used acetylcysteine in patients who were undergoing contrast studies for radiological investigation. That study, in fact, showed that there was an advantage in preventing acute kidney injury using acetylcysteine. There have been subsequent studies which, in fact, have shown that just adequately restoring intravascular volume with normal saline probably achieves the same result. So even though there are theoretical advantages of acetylcysteine from that single study, and also it's an antioxidant, so of course there's a physiological reason for its benefit, there certainly hasn't been any well-designed prospective randomized controlled trial to show that acetylcysteine attenuates acute renal injury or prevents acute renal injury.
So Dr. Zahid Sheikh has also raised his hand. Dr. Zahid, are you there? Dr. Zahid, you can unmute your mic and ask question.
So his mic is still muted, I can see that.
I don't know, I've asked him to unmute his mic. He can actually unmute his mic. Dr. Zahid, you can unmute your mic. Or maybe you can write a question. In the meanwhile, we are taking the question from Hafizullah. He's asked, with the rise of evidence-based practice, how do you see the integration of AI and machine learning in predicting and managing AKI in the intensive care setting? Quite an interesting question these days. It's quite, AI is everywhere. So Dr. Botha, would you like to answer that question?
I have to laugh myself. As you can see how I took a while to open up my PowerPoint. I'm not the most technically astute person, but I would answer the question like this. There's no doubt about it that much of medicine is really based on making informed decisions on the data we have before us. And certainly there are signals that predict which patients are going to progress to acute tubular necrosis and move from that pre-renal stage to established necrosis of the tubules with granular cost, etc. And there are unquestionably many risk factors for that. Pre-existing chronic renal disease such as diabetes, hypertension, patients with low blood pressure, patients who've had surgery, patients who've had nephrotoxic agents, patients who've got known vascular disease. So to answer the question, I think there certainly will be a role for AI with very sophisticated algorithms that integrate all that data into an AI-driven protocol, an AI-driven therapy. I believe that will happen with time.
Thank you, Dr. Botha. Dr. Zahid is still there, and I'm trying to get him connected. He has again asked me to unmute his mic, but yes. Dr. Zahid, you just click once and that would be fine. Because I just saw that it got unmuted and then again it was muted. So just click your mic for unmute only once. I wish I can unmute you otherwise.
Thank you, David Botha, for giving such a nice talk. I have a question. From practical point of view, we've seen elderly geriatric patients who are coming with septic shock. It's very difficult to maintain the U volume on those patients. Most of the time, what I've seen, the patients become over hydrated. So what is your experience in this situation? How we can make the patient euvolemic, and how we can maintain this so as to prevent the acute?
That is a wonderful question and a very difficult question to answer, and I still grapple with it. And the reason I grapple with it is because we have so many tests over the last 2 or 3 decades to try and establish what the patient's preload should be. For example, we look at various devices such as Vigileo monitors, such as Swan-Ganz catheters, such as CVPs, and of course, recently ultrasound. And the real problem with all of those is that all of them have got their limitations. And the real difficulty we face in elderly patients is sometimes what we're dealing with is mixed pathology. We're dealing with the patient where the problem may be related to their volume, but often a heart which is not normal, so that these patients are not preload responsive. And that makes it particularly difficult. So what is my approach? What is my approach? And I can't say it's evidence-driven, but I could say it is after 35 years of intensive care experience. If the patients are really sick and I'm concerned about how much urine they're passing, the most important thing that worries me initially is what their saturations are. The measurements are helpful and supportive, but if there's not fluid inside the lung and they're breathing relatively comfortably, I tend to be liberal with fluid in the early stages, even if the JVP is up, even if they've got leg edema, because it's hard to know how that patient's kidneys are going to respond. And if they're not desaturating and the gas exchange is good and the AA gradient is acceptable, I think it's reasonable in those patients to restore the blood pressure, because as I've said earlier, that French study showed that higher blood pressure is better in these patients, and I'm generous with fluid in these patients, because if their gas exchange is good, I don't believe you're causing them any significant immediate harm. Of course, the dilemma we often face as intensivists, particularly with my renal background, is one sometimes comes into conflict with our cardiology colleagues who may have a more conservative view on that. So that is my answer. It's difficult, but I would be quite generous with fluids in the early stage.
Thank you. Indeed, this will be very helpful for us. Thank you.
Thank you so much. Dr. Zahid has asked question that my question was more for the chronic renal failure that we see in elderly patients with the low GFR, and they are difficult to treat. So I think that was his question, or maybe a remark from you.
Yeah, and that's the real dilemma we face. And the point I wanted to make earlier, which I didn't articulate very, very well, is that there's an inverse relationship between GFR and serum creatinine. And as many of you will recall, your serum creatinine only goes up when your GFR falls to about 50% of normal. So the problem really is that the elderly patient, the elderly hypertensive diabetic patient, who may have a marginally elevated serum creatinine, but they're at the inflection point there. So any slight insult that drops their GFR is going to cause a precipitous increase in their serum creatinine. And that's a dilemma we often face in the elderly patients. They come into the operating theatre to have a major procedure. Their serum creatinine is 105 or 110, and a minor change in their GFR will cause a substantive increase in the serum creatinine. And that's the dilemma we face in the elderly patient. And that's where we've got to be particularly careful about restoring the blood pressure or maintaining the blood pressure, early recognition of oliguria, and being absolutely clear about what drugs we're going to administer, particularly gentamicin, vancomycin, non-steroidal anti-inflammatory drugs, ACE inhibitors, etc. I stop all the drugs in the perioperative period unless it's absolutely essential at a point in time.
So thank you so much, Dr. Botha. I think, Dr. Zahid, this answers your question. I'm really grateful to Dr. Botha from behalf of the PSA Karachi on giving us this online lecture. And it was really nice to hear the prospect from all sides, and especially from your country. And really thankful to you, Dr. Botha. And thanks to all the participants. I would request all the participants to please fill in the feedback form so that they can get the e-certificate. And Dr. Botha, hopefully you'll get your certificate and the feedback within a week's or 2 weeks' time. Hope to see you soon again. Thank you so much for your time.
Thank you so much, Asma, and to all my colleagues from Pakistan. I thought your questions were absolutely fantastic. It was a really enjoyable evening for me, and I certainly hope to meet some of you when I have my next visit to Pakistan, which at this stage is
Hopefully.
planned for April next year. Take care and have a lovely evening. Good night, everybody.
You too. Take care and have a good night.
Bye-bye. Bye-bye.
Goodbye and thank you, everyone. We will see you again
Thank you.
in 2 weeks' time with a new module on pain management. Thank you, everyone.